Chapter 33, Assessment of the Hematologic System. The priority concepts for this chapter are clotting and perfusion. Components and organs responsible for blood formation, circulation, function, storage, and recycling are contained within the hematologic system. Blood cells, lymph nodes, bone marrow, and the spleen, liver, and thymus are included in the system. Formation and circulation of normal blood are critical to tissue perfusion and gas exchange because the blood is the oxygen delivery system. Perfusion is the total arterial blood flow through the peripheral tissues and blood that is pumped by the heart to oxygenate major organs. Tissues and organs depend on blood for perfusion and oxygen delivery, so any problem of the hematologic system affects total body health. Part of maintaining adequate whole body perfusion is ensuring that liquid blood circulates properly to deliver oxygen to all cells, tissues, and organs. Clotting also is a critical function of the system. Clotting is a complex, multi-step process by which blood forms a protein-based structure or clot in an appropriate area of tissue injury to prevent excessive bleeding while maintaining perfusion. Bone marrow is the spongy tissue inside bones that produces red blood cells, RBCs, erythrocytes, white blood cells, WBCs, leukocytes, and platelets, or thrombocytes. Bone marrow also is involved in the immune response. Billions of RBCs, millions of platelets, and 1 billion white blood cells per kilogram of body weight are released from the bone marrow daily. The cell-producing part of the marrow is present only in flat bones, which include the sternum, skull, pelvic, and shoulder girdles, and the ends of the long bones. With aging, fatty tissue replaces active red bone marrow. The older adult can still manufacture the amount of blood cells the body needs. However, older adults are more vulnerable to health disorders associated with problems of oxygen, clotting, and perfusion, as they do not have the same reserve that a younger adult has. Bone marrow first produces immature blood stem cells, which are unspecialized or undifferentiated cells that are capable of becoming any type of blood cell, depending on the body's needs. The next stage in blood cell production is a committed stem cell, or precursor cell. A committed stem cell enters one growth pathway and can at that point specialize or differentiate into only one cell type. Committed stem cells actively divide but require the presence of a specific growth factor for specialization. For example, erythropoietin is a growth factor specific for the red blood cell. Other growth factors control white blood cells and platelet growth. Hemostasis is a multi-step process of controlled blood clotting, resulting in localized blood clotting in damaged blood vessels. Helps to prevent excessive blood loss while continuing perfusion of liquid blood and individual cells to all other areas. It balances the blood clotting actions within anti-clotting actions. When injury occurs, hemostasis starts the formation of a platelet plug and continues with a series of steps that eventually cause the formation of a fibrin clot. Three sequential processes result in blood clotting: platelet aggregation with a platelet plug formation, the blood clotting cascade, and the formation of a complete fibrin clot. Platelet aggregation begins forming a platelet plug by having platelets clump together, a process essential for blood clotting. Platelets normally circulate as individual small cells that do not clump together until activated. Activation causes platelet membranes to become sticky, allowing them to clump together. When platelets clump, they form large, semi-solid plugs in blood vessels, disrupting local blood flow. They last only a few hours. They cannot provide complete hemostasis, and they only trigger the start of the hemostatic process. Platelets secrete substances that activate platelets and cause clumping, making platelets available to continue self-activation, including adenosine diphosphate, or ADP, calcium, thromboxane, or TXA2, and collagen. Other activating substances are external to the platelet. The platelet plugs start the cascade action that ends with local blood clotting and are important at all steps within the cascade. When too few platelets are present, clotting is impaired. This increases the risk for excessive bleeding. The blood clotting is a cascade triggered by platelet aggregation and the formation of the platelet plug, which then rapidly amplifies the cascade. Cascade reactions are hard to stop once they are set in motion. Normal blood clotting is triggered initially by conditions that activate either of the two district pathways, the extrinsic pathway, which is outside the blood vessel, and the intrinsic clotting pathway, which begins with changes in the blood rather than with trauma. These passageways merge later in the cascade, forming a common path to result in a stable clot for hemostasis. Anti-clotting forces limit clot formation to only the damaged area and normal perfusion to maintain everywhere else. When blood pro-clotting and anti-clotting actions are balanced, clotting occurs only when it is needed and normal perfusion is maintained. Anti-clotting forces. They ensure that activated clotting factors are present only in limited amounts. It can cause fibrinolysis, which is the process that dissolves fibrin clot edges with specialized enzymes to prevent over-enlargement of the fibrin clot. The older adult has a decreased blood volume with lower levels of plasma proteins. The lower plasma protein level may be related to reduced dietary intake of protein and to a reduced protein production of the aging liver. As bone marrow ages, it produces fewer blood cells. Total red blood cell counts are lower among older adults. Hemoglobin and hematocrit levels are slightly reduced in older adults. Platelet counts are reduced in adults over the age of 60. Lymphocytes become less reactive to antigens and lose immune function, so they are not as protective when the older adult is exposed to infection. Antibody levels are lower and response times are slower in older adults. The white blood cell count may not rise as high in response to infection in older adults as it does in younger adults. Age and sex are important to consider when assessing a patient's hematologic status. Bone marrow function and immune activity decrease with age. When taking a history, ask about the presence of unknown immunity, liver, or hematologic disorders. Ask whether there is a history of cancer, and if so, whether radiation therapy was used. This type of treatment can impair hematologic function in marrow-forming bones, where it is the path of radiation. Ask about the patient's occupation and hobbies, and whether the patient's home is located near an industrial setting. This information can help you to identify exposures to agents that affect bone marrow and hematologic function. Consult the electronic healthcare record to ask the patient about vaccination status for COVID-19. Also ask if the patient has a history of COVID-19. If the patient has a history of COVID-19 and received the vaccine, determine which vaccine was received and when the patient was immunized. If the patient received the Johnson & Johnson, the Janssen, or AstraZeneca COVID-19 vaccine 4 to 42 days prior to the onset of symptoms, ask whether the patient has experienced severe headache, visual changes, abdominal pain, nausea and vomiting, bone pain, shortness of breath, leg pain or swelling, petechiae, easy bruising, or easy bleeding. Report positive findings to the primary healthcare provider right away. These factors could be indicative of a vaccine-induced thrombotic thrombocytopenia. This is known as VITT. It is a syndrome characterized by simultaneous acute thrombosis and thrombocytopenia. Although VITT is a rare complication of vaccine and can often be treated with intravenous immunoglobulin and non-heparin anticoagulants, early intervention is critical. Delayed recognition and treatment can lead to fatality. If the healthcare provider suspects VITT, the provider will order a complete blood count with platelet count and peripheral smear, a D-dimer test, a fibrinogen test, a PF4 heparin enzyme-linked immunosorbent assay test. Check all drugs the patient is using or has used in the past month. Look at the electronic health record and also ask about the use of drugs that are known to affect the hematologic function. Ask the patient about the use of anticoagulant agents and NSAIDs, which change the blood clotting activity. Many patients refer to anticoagulants as blood thinners, although they do not change blood thickness or viscosity. Anticoagulant drugs work by interfering with one or more steps involved in the blood clotting cascade. These agents prevent new clots from forming and limit or prevent the extension of formed clots. Anticoagulants do not break down existing clots. These drugs are classified as platelet inhibitors or antiplatelet drugs, direct thrombin inhibitors or indirect thrombin inhibitors, and vitamin K antagonists. Fibrolytic drugs, also known as thrombolytic drugs or clot busters, selectively break down fibrin threads present in formed blood clots. The mechanism starts with activation of the inactive tissue protein plasminogen to its active form, plasmin. Plasmin directly attacks and degrades the fibrin molecule. Fibrolytic drugs include the IV agents antiplase, retiplase, and tentaclase. Food intake and dietary can alter cell quality, affect clotting, and influence the overall health of a patient's hematologic system. Diets high in fat, salt, and sugar are linked to the development of anemia. Ask patients what they have eaten during the past week and whether any supplements have been taken. Using this information to collaborate with a registered dietitian or nutritionist to assess possible iron, protein, mineral, or vitamin deficiencies. Also ask about alcohol consumption because chronic alcohol misuse can cause nutritional deficiencies, impact the liver, and increase the risk for bleeding and thrombus. Ask about personal resources such as finances and social support and where the patient lives. An adult with a reduced income or one who lives in a food desert may have a diet deficient in iron and protein because food containing these substances are more expensive or unavailable. Assess family history because many disorders affecting blood and clotting are inherited, especially those affecting the production of clotting factors and anti-clotting substances. Ask whether anyone in the family has had hemophilia, frequent nosebleeds, postpartum hemorrhage, excessive bleeding after tooth extraction, or heavy bruising after mild trauma. Ask whether the family member has sickle cell disease or a sickle cell trait. Although sickle cell disease is seen in North America often among Black or African American people, anyone can have the trait. Asking whether conditions associated with excessive clotting exist within the family is also important to identify a possible genetic problem triggering the intrinsic clotting pathway. Ask about lymph node swelling, excessive bruising or bleeding, and whether the bleeding was spontaneous or induced by trauma. Ask whether there is excessive bleeding after routine dental work and how long it lasts. Have women estimate the number of pads or tampons used during the most recent menstrual cycle and determine whether amount is bleeding is heavy or represents a change from the usual pattern of flow. Ask whether clots are present in menstrual blood. If so, estimate the clot size using common items such as a quarter or a walnut for comparison. Assess and document whether the patient has shortness of breath and exertion, palpitations, frequent infection, fevers, recent weight loss, headache, or paralysis. One, all, or any combination of these symptoms may occur with a hematologic disorder. The most common symptom of anemia is fatigue due to decreased oxygen delivery to cells. Cells use oxygen to produce the high-energy chemical adenosine tryptophan, or ATP, needed to perform most cellular work. When oxygen delivery to cells is reduced, cellular work decreases and fatigue increases. Ask the patient about feeling tired, needing more rest, or losing endurance during normal activities. Ask them to compare their activities during the past month with how they felt a year ago. Determine whether other symptoms of anemia, such as vertigo, tinnitus, or inflamed or swollen tongue, or a smooth and red tongue are present. Next, we perform a full physical assessment, as blood problems may reduce oxygen delivery and tissue perfusion to all systems. Determine whether certain symptoms in older adults are related to aging or could indicate a hematologic condition. Remember to gently examine the patient with or suspected of having a hematologic condition to avoid causing bruising, petechiae, or excessive bleeding. Inspect the skin and mucous membranes for pallor or jaundice and the nail beds for pallor or cyanosis. Pallor may look whitish, bluish, or ash-gray in appearance depending on the patient's normal skin tone. Additionally, assess the gums, conjunctivae, and palms for color change that may indicate pallor, jaundice, or cyanosis. This is an important technique to use when assessing older patients and patients of color to prevent disparities in health equity. Pallor of the gums, conjunctivae, and palmar creases, where the palm is stretched, can indicate decreased hemoglobin levels and poor tissue oxygenation. When we are assessing the gums for active bleeding in response to light pressure or brushing the teeth with a soft bristled brush, and assess for lesions or areas with impaired tissue integrity. Inspect for petechiae and large bruises or ecchymosis across the body. Petechiae are reddish-purple pinpoint hemorrhagic lesions in the skin. Bruises may cluster together. For hospitalized patients, determine whether there is bleeding around the nasogastric tube, the endotracheal tubes, central lines, peripheral IV sites, or Foley catheters. Check the skin turgor and ask about itching because dry skin from poor perfusion itches. Assess body hair patterns. Areas with poor circulation, especially the lower legs and toes, may have sparse or absent hair, although this may be a normal finding in the older adult. Check for pallor, ulceration, and color changes in the oral mucosa, such as fissures at the corners of the mouth. Pallor of the mucosal membrane may be assessed as lighter than expected in appearance or as bluish purple or ash gray. Patients with pernicious anemia or iron deficiency anemia may have tongue changes such as smoothness, beefy redness, or swelling. Use an evidence-based tool such as the Oral Mucositis Risk Assessment Scale in hematology patients for patients with a hematologic problem undergoing chemotherapy or radiation. These treatments can greatly affect the oral mucosa. Prevention and treatment of the undesirable side effects can be initiated quicker when assessing with an evidence-based tool. We want to inspect and palpate all lymph node areas. Document the location of any lymph node enlargement, as well as the size, whether palpation causes pain, and whether the node is fixed or moves when palpated. When hematologic problems reduce oxygen delivery, the lungs work harder to maintain tissue perfusion. We want to assess the rate and depth of respiratory rate while the patient is at rest and during and after mild physical activity, like walking 20 steps in 10 seconds. Note whether the patient can complete a 10-word sentence without stopping for a breath. Assess whether the patient is fatigued easily, has shortness of breath at rest or on exertion, or needs extra pillows to breathe while they are sleeping. Anemia can cause these problems due to respiratory changes related to reduced tissue oxygen levels. When blood problems reduce oxygen delivery, the heart works harder to maintain tissue perfusion. Pulses may become weak and thready. Observe for distended neck veins, edema, or indications of phlebitis. Listen for abnormal heart sounds and irregular rhythms, and obtain a blood pressure. Bleeding problems can cause hematuria. You want to inspect the urine for color. Hematuria may be seen as grossly bloody urine, as red or pink or cola-colored. Test the urine for proteins with a urine dipstick because blood contains protein and blood in the urine increases its protein content. The adult with chronic kidney disease produces less natural erythropoietin and often is anemic. People with subacute kidney injury can also become anemic from bleeding or hemolysis. Rib or sternal tenderness sometimes occurs with certain types of leukemia when the bone marrow overproduces cells, increasing the pressure in the bones. Perform this assessment by applying light to moderate pressure with the fingertips on the sternum. Assess the range of joint motion and document any swelling of the joint pain. The normal adult spleen is usually not palpable, but an enlarged spleen occurs with many hematologic problems. The primary healthcare provider will perform this assessment because an enlarged spleen is tender and can rupture easily. The primary healthcare provider will also perform palpation of the liver. Chronic bleeding from a GI ulcer or intestinal polyps can cause anemia. Ask patients about changes in bowel habits or whether they have noted any blood in their stool. Obvious blood may not be visible in the stool, or such a small amount is passed each day that patient is unaware of it. Obtain a stool specimen for occult blood testing. Hematologic conditions can cause specific changes in the central nervous system. Vitamin B12 deficiency impairs nerve function, and severe chronic deficiencies may cause permanent neurologic degeneration. Many neurologic problems can develop if patients who have had certain types of leukemia or lymphoma that involves or spreads to the CNS. When the patient with a suspected bleeding disorder has any head trauma, expand the assessment to include frequent neurologic checks. Regardless of the type of hematologic problem, each patient has individual coping mechanisms. We want to develop a rapport and listen with coping mechanisms have been working for this patient, and then use them successfully in the past, or whether collaboration with the primary healthcare provider for a mental health referral may be indicated. Laboratory test results provide definitive information about hematologic problems. When a venipuncture is necessary, we want to apply pressure to the site in the patient with or suspected of having hematologic problem. This action can prevent bleeding and hematoma formation. Maintain pressure until the bleeding from the venipuncture has stopped. This can take several minutes. A peripheral blood smear is made by taking a drop of blood and spreading it across the slide. It can be read digitally or by a technologist with a microscope. The rapid test provides information on the sizes, shapes, and proportions of red blood cells, white blood cells, and platelets within the circulating blood. A complete blood count, including a red blood cell count, hematocrit, hemoglobin, white blood cell count, red blood cell indices, and platelet count. A complete blood count with differential also determines the percentage of different types of leukocytes circulating in the blood. The RBC count measures circulating RBCs in 1 millimeter to the third of blood. The white blood cell count measures all leukocytes present in 1 liter of blood. A white blood cell count and differential includes the percentages of neutrophils, lymphocytes, monocytes, eosinophils, and basophils. The hematocrit is the percentage of RBCs in the total blood volume. The hemoglobin level is the total amount of hemoglobin in the blood and is measured in grams per deciliter. The CBC can measure other features of their RBCs, called the red blood cell indices. The mean corpuscular volume, or MCV, measures the average size of individual red blood cells and is useful for classifying anemias. When the MCV is elevated, the cell is larger than normal, or macrocytic, as seen in megaloblastic anemias. When the MCV is decreased, the cell is smaller than normal, microcytic, as seen in iron deficiency anemias. The mean corpuscular hemoglobin is the average amount of hemoglobin by weight in a single red blood cell. The mean corpuscular hemoglobin concentration measures the average amount of hemoglobin by percentage in a single red blood cell. When the MCHC is decreased, the cell has a hemoglobin deficiency and is hypochromic, or lighter in color, as in iron deficiency anemia. The red blood cell distribution width is a calculation of variation in the sizes of red blood cells. These tests can help determine the possible cause of low red blood cell counts that are not related to blood loss. The platelet count, also known as the thrombocyte count, reflects the number of platelets in circulation. The normal range is 150,000 to 400,000. When the value is low, or thrombocytopenia, the patient is at a greater risk for bleeding because platelets are critical for blood clotting. Patients who have values between 40,000 and 80,000 may have prolonged bleeding from trauma, dental work, and surgery. A platelet value below 20,000 is considered critical. The patient may have spontaneous bleeding that is very difficult to stop. Tests that measure bleeding and coagulation provide information that reflects the effectiveness of different aspects of blood clotting. These tests are used to diagnose specific hematologic health problems, determine drug therapy effectiveness, and identify risk for excessive bleeding or clotting. PT, or prothrombin time, measures how long blood takes to clot, reflecting the levels of clotting factors 1, 2, 5, 7, and 10, and how well they are functioning. When enough of these clotting factors are present and functioning, the PT shows blood clotting between 11 and 12.5 seconds, or within 85 to 100% of the time needed for a control sample of blood to clot. PT is prolonged when one or more of these clotting factors are deficient. The PT test is now used less often to assess how fast blood clots because control blood is taken from different adults and may not be the same even in one laboratory from one day to the next. To reduce PT errors as a result of controlled blood variation, or in some of the chemicals used in the test, the International Normalized Ratio, or INR, is used to assess clotting time. The INR measures the same process as the PT by establishing a normal mean or standard for PT. The INR is calculated by dividing the patient's PT by the established standard PT. A normal INR ranges between 0.8 and 1.1. When using the INR to monitor warfarin therapy, the desired outcome is usually to maintain the patient's INR between 2 and 3, regardless of the actual PT in seconds. However, the desired INR range is individualized to each patient according to individual factors and medical conditions. The next thing that we talk about an assessment is a diagnostic assessment. Standard x-rays may be used to diagnose certain hematologic problems. For example, multiple myeloma caused classic bone destruction that looks like holes in the bones on an x-ray. A chest x-ray can indicate the presence of a tumor and enlarged lymph nodes. A CT scan can be used to detect enlarged lymph nodes. A fluorodexaglucose postern emissions tomography, or an FDG PET scan, can be used to detect lymphoma and multiple myeloma. Magnetic resonance imaging, or MRIs, can be used to assess for possible lymphoma for visualization, leukemia for bone marrow abnormalities, and myeloma for detection and staging. It can also be used to assess bone changes, especially those that occur with myelomas. Prepare patients for these tests according to agency policies. Skeletal scintigraphy, also known as a bone scan, is a nuclear medicine scan used to help with the diagnosis and evaluation of bone diseases. Small amounts of radioactive material or radiotracers are given by injection, aerosol gas, or orally. They are then visualized on screen by the camera that detects gamma waves given off by the radiotracers. The patient is given a radioactive isotope before the procedure. If the patient is anxious due to claustrophobia, an anxiety medication can be given. The patient must lie still for an hour during the scan. No special patient follow-up care is needed other than to remind the patient that the radioactive material will be eliminated within a few hours following the test. We want to encourage the patient to drink water to increase urination. If the patient is going to a location that has screening equipment, such as an airport, a train station, or a sensitive workplace, we want to teach the patient that the materials may be detected for several days. Collaborate with the healthcare provider to provide the patient with documentation showing that they recently underwent a scan of their skeletal examination. Information obtained from bone marrow aspiration or biopsy can be used to diagnose certain cancers, anemias, or other blood disorders. These procedures are often done when other tests show potential problems in blood cell production or maturation. Results provide information about bone marrow function, including the production of all blood cells and platelets. In a bone marrow aspiration, cells and fluids are suctioned from the bone marrow with a special thin needle. This is usually taken from the iliac crest, although it can be retrieved from the sternum or femur. During a bone marrow biopsy, cells, fluid, and a small amount of bone are retrieved with the larger needle. Done together, these procedures take about 30 minutes. A primary healthcare provider's orders and a signed informed consent form are obtained before either procedure is performed. Bone marrow aspiration may be performed by a physician or an advanced practice nurse, depending on the agency's policies in states or province laws. The procedure may be performed at the patient's bedside in the hospital or in an ambulatory setting. After learning which specific tests will be performed on the marrow, check with the hematology laboratory to determine how to handle the specimen and follow agency policy. Most patients are anxious before a bone marrow aspiration, even those who have had one in the past. You can help reduce anxiety and allay fears by providing accurate information and emotional support. You want to check with a healthcare provider to determine whether blood thinning agents should be continued or discontinued prior to the procedure. If they are being discontinued, teach the patient when to stop the drugs and when to restart after the procedure. The patient does not need to be fasting for a bone marrow aspiration or biopsy. We want to explain the procedure and reassure the patient that you will be staying the entire procedure. Tell the patient that a local anesthetic injection will be given first and that it will sting or burn. Tell the patient to expect a heavy sensation or pressure and a pushing while the needle is being inserted. Sometimes a crunching sound can be heard or a scraping sensation felt as the needle punctures the bone. Explain that the patient will feel a brief sensation of painful pulling as the marrow is being aspirated by mild suction in the syringe. If a biopsy is performed, the patient may feel more discomfort as the needle is rotated into the bone. Help the patient onto an examination table and expose the site. If the iliac crest is being used, place the patient in the prone or side-lying position. Depending on the test to be performed on the specimen, a laboratory technician may be present to ensure its proper handling. During the procedure, a local anesthetic agent is injected to the skin around the site. The patient may also receive a mild tranquilizer or a rapid-acting sedation such as Versed or Ativan. The skin over the site is cleaned. We want to observe for sterile technique during the procedure. For an aspiration, the needle is inserted with a twisting motion and the marrow is aspirated by pulling back on the plunger of the syringe. When sufficient marrow has been aspirated to ensure accurate analysis, the needle is withdrawn rapidly while the tissues are supported. For a biopsy, a small skin incision is made and the biopsy needle is inserted. Pressure and several twisting motions are needed to ensure coring and loosening of an adequate amount of marrow tissue. We want to apply external pressure to the site until hemostasis is ensured. A pressure dressing or a sandbag may be applied to reduce bleeding at the site. For follow-up care, the nursing's priority after a bone marrow aspiration or a biopsy is to prevent excessive bleeding. We want to cover the site with a dressing after bleeding is controlled and closely observe it for 24 hours for signs of bleeding and infection. If the patient goes home the same day as the procedure, instruct the patient to inspect the site every 2 hours for the first 24 hours to assess for active bleeding or bruising. We want to advise the patient to avoid any activity that might result in trauma to the site for the next 48 hours and contact the healthcare provider if discharge, bleeding, swelling, or warmth arise. Remind the patient that mild pain may be felt around the needle insertion site or in the back for several days. A mild analgesic that's aspirin-free may be given for discomfort, and ice packs may be placed over the site to limit bruising. A lymph node biopsy can be performed to assess for cancer cells. It can also be used to confirm the diagnosis of lymphoma. The biopsy can be done by fine needle aspiration, core needle aspiration, or surgical removal. Like bone marrow aspiration or biopsy, this procedure can be done in a hospital or in an ambulatory setting. Depending on the type of approach that will be used, follow agency policy to prepare, monitor, and teach the patient about appropriate follow-up care.